Okay, Assalamu alaikum everyone. Good evening. Welcome, a very warm welcome to another Emirates Diabetes and Endocrine Society Connect activities. And this time we're moving to a completely different paradigm. This time we are convening in a round table around dyslipidemia masterclass activity. And this will be an activity that's composed of four waves. This is the first wave, and we're very delighted to have top tier experts, local, regional, and international experts who will be teaching us on the foundations of lipidology and cardiovascular risk and risk assessment and management. For I know most of the colleagues around, but for those who don't know me, my name is Alamin Abdel Gadir. I'm a consultant endocrinologist and associate professor of endocrinology at Mohammed bin Rashid University, and I'll be very honored and delighted to moderate this session. So, similar to the previous activities in the MS Diabetes and Endocrine Society Connect, this activity will be in live streaming in the YouTube. So, for those who are not able to join through the Zoom link, they can watch the activity live happening now in the YouTube. And this activity will be awarded by CME Hours. This expected to be distributed back within 3 to 4 weeks after we end this activity. And I urge all of you, please, to make this more interactive. Whenever we have any question, to write it down in the Q&A section. We'll come to the discussion at the end of the talks series. And after we finish this activity, all the videos of these four waves will be available in the Emirates Diabetes and Endocrine Society Institute website. And this is the link in case of anyone wanted to revisit this contents at a later stage. So, as I've mentioned, today we'll be in a roundtable with top tier experts that telling us or teaching us about the foundations of lipidology. And as you can see, we'll start with Professor Hussein Hishmet, and then we move forward hovering from the basics of lipidology to advances in clinical management and how to take good care of our patients in cardiovascular risk paradigm. So, without any further ado, the first talk will be from the lipoprotein biology, the road to plaque destabilization. And we are so delighted to have Professor Hussein Hishmet with us, teaching us on that. He's very known to so many of us and has been a regional expert in cardiology and interventional cardiology. He's a professor of cardiology at various universities back in Egypt and the United Arab Emirates. He is a fellow of most prestigious international professional societies, including American College of Cardiology, European Society of Cardiology, and others. He is our national expert in the interventional cardiology with a vast experience in most of the complex and complicated cases where he has accomplished over thousands of advanced interventional procedures across the globe. So, without any further ado, Professor Hussein Hishmet, the floor is all yours, and please start.
Thank you, Dr. Amin, for this kind introduction. I'm honored to be among this group of international and local experts, including authors of the guidelines that we are trying to adopt. And I would like to thank the participants, more than 300. I can see the numbers, very encouraging. So let's start. I hope you can see my slides, right? So I have a small disclaimer here. It's not related to any relation to the industry, but the disclaimer here is that we're going to try to explain the basics of atherosclerosis, lipoproteins, and their interaction. And when we go to the basics of physiology and pathology, we think that this is the truth, whereas in fact it's not the truth. The truth for a person or for a clinician like me, a cardiologist, the truth is death, the truth is MI, the truth is stroke. Not the molecules that we will see and their interactions. This is an attempt to understand why things happen on the ground, why people get a myocardial infarction, why they get stroke, why people die. So this is not the truth, but this is an attempt to understand the truth. And I'll try to be as basic as possible, and I'll try to answer the most important questions about lipoproteins and atherosclerosis. So the basic question, why do we have lipoproteins in our blood? And the answer is simple, because our bodies are mostly made of water. Blood is an aqueous fluid, and it's akin to the analogy where you're trying to move oil in the sea. You need a ship, you need a vessel, you need a cargo. And this cargo is encaged as the lipoprotein. It has a shell and outer surface that's compatible with the aqueous environment, with water. It's amphipathic, it's water soluble. And inside this shell is, we'll see the package that is the lipids that our bodies need, the triglycerides, which have fatty acids and an acyl backbone, in addition to cholesterol. And these lipoproteins, they're not just the shell of phospholipids, but this shell also has markers, or the flags. You know, every ship that's moving in the sea should have a flag to get its identity, so that it can identify where's the final destination, so it can be easily handled by the destination. And inside we have a mix of triglycerides and cholesterol, and sometimes free cholesterol. And these lipoproteins, they come in different shapes, different sizes, and different compositions. And depending on the size, we classify them into high density, intermediate density, low density. And the biggest one among them is the chylomicrons, and we will discuss shortly where do they come from and what's their fate. But the first difference among these lipoproteins is in the size and in the density. And the general rule is, as the size gets bigger, then they become lighter in weight. The biggest molecule is chylomicron. This has a big percentage of triglycerides, and it is the least dense, so it has the smallest weight. Then we move down into smaller sizes, and as the size gets smaller, the density gets bigger. So along the way, we have very low density, intermediate density, low density, and then we have the high density, each with different size. But we will see in the pathophysiology why this size is important. Why the chylomicrons, although they have a large content of triglycerides, they are not implicated in atherosclerosis, because they are simply too big to penetrate the arterial wall. Not only different in sizes, but also different in composition. Chylomicrons are mostly triglycerides. VLDL, that come from the liver, or it has a 60% triglycerides, where the molecule that harbors most of the cholesterol, most of its content of cholesterol, is low density lipoproteins. And as we mentioned, each of these carriers or vessels must have a flag, and this flag is the apolipoprotein. What's the value of this flag? It helps to maintain the integrity of the molecule, and it helps to connect to the receptor or activate the enzymes which would either utilize this molecule, the lipoprotein, or degrade it as part of its degradation pathway. And we'll see shortly why these flags are important in risk assessment and in the pathophysiology of atherosclerosis. There are plenty of apoproteins. I need you to remember the ApoB100, and I'll explain shortly why, and the ApoE. So the ApoB is the flag or the marker on LDL, and intermediate density lipoprotein, and VLDL, whereas ApoE is the flag or the apoprotein on the remnant lipoproteins, and we'll discuss shortly what are remnant lipoproteins. So ApoB100 for VLDL, intermediate density, and LDL. And we have also Apo little a. The terms can be a little bit confusing. So Apo capital A is for HDL, whereas small a is for lipoprotein little a, and we'll explain shortly. So these are the lipoproteins that can be found in the blood or in the human body. So what do we measure actually when we take a blood sample from the patient? We do not actually measure the number of the particles. We do not measure the number of LDL particles or HDL particles. What we measure is the mass of cholesterol which is carried by each of these particles. And why is that important? Because there's not always a one-to-one correlation between the mass that's being carried in the blood and the number of the particles. And we will see when it comes to pathophysiology why when we have smaller particles and a bigger number of particles, it's more important than the mass of cholesterol. So that one particle has maybe rich in cholesterol, but when it is broken down into 4 particles, these 4 particles will be more atherogenic than one bigger particle. So we've discussed the lipoproteins that we have, the chylomicrons, VLDL, LDL, IDL, and HDL, and lipoprotein A. They exist in the blood, but where do they come from? Well, they come from 2 pathways. They are either engulfed in the food that we eat, or they are synthesized by the liver. When we ingest a fatty meal, then the intestines have to handle this meal so that it can be utilized by the body. We call that the exogenous pathway or the imported pathway. And there's another pathway where the body is able to synthesize its own cholesterol and fatty acids. This is the intrinsic pathway. They efflux them to the blood to be utilized by different body organs. And we have a third pathway, which is the reverse transport or the clearance pathway, where another molecule takes out the cholesterol out from the blood vessels and out of the organs into their elimination and degradation pathway. Quickly going through the exogenous pathway, the chylomicron is the main star here. It's the main player. It's synthesized from the fats that we take in the intestinal mucosa. It's mainly composed of triglycerides, and the marker is B48 and ApoE. Then these particles are the biggest particles, and if someone ingests a fat-rich diet, then the blood will become a little bit milky. This milky texture of the blood or milky appearance of the blood comes from the chylomicrons. Once they enter the circulation through the thoracic duct and in the capillaries, they are rapidly broken down by the famous enzyme lipoprotein lipase. Lipase clears away the triglycerides, and the chylomicron becomes a chylomicron remnant. And then this remnant that has another flag, which is ApoE, is cleared away, is degraded, removed away from the body by the LDL receptor. So that's the exogenous pathway. But our bodies are able to synthesize its own need of cholesterol and fatty acids. We need the diet, but our body is doing the bigger part of the job. And here the liver is the powerhouse. The liver is the center of command. It not only clears these lipoproteins, but it also synthesizes the lipoproteins. And the star molecule, the beginning molecule here, is the VLDL. VLDL, once it is released, it's broken down by lipoprotein lipase, takes out some triglycerides, it becomes the LDL. It first becomes the intermediate density lipoprotein, then it becomes the low density lipoprotein. This low density lipoprotein will circulate in the blood, and then after it serves its function, it has to be cleared by the liver again through the LDL receptor. And so what's the function of LDL? Does it serve a physiologic function? Well, cholesterol is important for bile acids, for sex hormones, for the integrity of the cell membranes. And LDL is the biggest carrier of cholesterol in our blood. So if it's excreted by the liver, it goes into the circulation where it can be taken by the cells. So it serves a physiologic function, but actually we do not need more than 30 milligrams per deciliter in our blood. And any excess than beyond the 30 milligrams is probably useless, and of course it's harmful. And as I told you, the truth comes from mortality, MI, and stroke. And all the epidemiologic data, the Mendelian randomization data, and the drug trials have shown us that the main culprit in atherosclerosis is the low density lipoprotein. And LDL has another twin brother that has some minor differences, and it's even more vicious than the LDL. We call that the lipoprotein little a. Lipoprotein A is almost identical to LDL, but it has an extra phospholipid molecule on its surface, and we'll see why this molecule is more dangerous because it's more prothrombotic. And we have the nice guy in the story, which is the HDL. The role of the HDL is to take away cholesterol from the arteries and from the tissues into the liver so that it's excreted. And this entails several enzymes and molecules, and these will be targets for future medications, which is going to be beyond the scope of today. So we've discussed the lipoproteins, where do they come from, and what are their physiologic function, and what's the flag on each of these lipoproteins. So what's the relation between these lipoproteins and atherosclerosis? We need to agree on that a fact that atherosclerosis is a disease of lipid logistics. It's mostly endogenous, whereas the exogenous pathway is just a modifier. But the main players are our innate systems. There's a chronic exposure in our bodies for VLDL and LDL. The main flag is ApoB100, whereas these dietary intakes are like spikes, which tend to worsen the situation, but alone they are not enough. Most of the elevations that we have in these lipoproteins are due to minor or major genetic mutations in the LDL receptor or in the PCSK9, which is a degrader of the LDL receptor. It could be the hepatic lipases or the lipoprotein lipases. And this would help us understand why the dietary approaches or the dietary modifications or even the best lifestyle has a limited impact on the LDL and the VLDL and has almost no impact on lipoprotein little a, because these levels of these lipoproteins in the blood is mostly dictated by minor or major genetic mutations. So how do these lipoproteins induce atherosclerosis? We'll look first into the ApoB100 particles. And the biggest proportion of ApoB100 molecules is the LDL. And as I told you, this is our bread and butter in combating atherosclerotic disease. LDL will become oxidized, will be taken by the macrophages and initiating atherosclerosis. So let's go quickly through this process. How does it happen? When we have an excess of lipoproteins, LDL, LPA, and the remnant particles, they induce some form of endothelial dysfunction. So they are able to penetrate through the endothelium into subendothelial matrix. And what happens once these LDL particles and their flag, the ApoB100, they have positive charges, and so they interact with the negative charges of the extracellular matrix, and they become sequestered from the plasma. So they become easily oxidized, and once they get oxidized, then all the vicious events start to happen. This oxidized LDL beneath the intima into the arterial wall, they are viewed as a foreign particle. They are viewed like a virus or a bacteria. And so monocytes migrate into the arterial wall and they start an inflammatory process, immune activation. But unlike the regular inflammatory process, for some reason, the macrophages, the receptors on the macrophages, they can keep engulfing oxidized LDL for almost forever. And the end result of that is that these macrophages, they keep growing, growing, growing. They are full of oxidized LDL, which looks like lipid droplets inside the macrophages, until these cells become foam cells. And whenever they are flooded by lipid droplets, these macrophages, they become overloaded and they cannot get rid of these lipid particles. And so instead of, they cannot keep growing forever, then they undergo apoptosis and they die. And so the end result of any inflammation and immune activation will be the formation of a necrotic core. These oxidized LDL particles also stimulate the vascular smooth muscles to form some fibrous tissue. It's like an abscess that has a necrotic core, and then the body tries to encapsulate that abscess with vascular smooth muscle cells. They produce collagen and fibrous cap that tends to engulf this necrotic core and try to segregate it away from the plasma. But these oxidized LDL particles and oxidized lipoproteins still keep their toxicity. They induce a change in the vascular smooth muscle cells. Instead of being contractile, they become synthetic, so the elastic nature of the blood vessel starts to be disrupted. Instead, they start to synthesize fibrous tissues, fibrous and collagen and fibrous tissues in order to try to contain the inflammation. And it's not only an inflammatory issue, but the lipoprotein little a, and I'm sure it's going to be covered by the next speakers, in addition to inducing the same foam cell and immune activation, it tends to cause activation of the thrombotic pathway because this extra molecule on the surface has structure similarity to plasminogen, so it inhibits fibrinolysis. So how do these so we've talked about the ApoB100, which is LDL, intermediate density lipoproteins, and lipoprotein little a. But these are not the only drivers of atherosclerosis. Triglyceride-rich particles are also driving atherosclerosis. We see that in patients with diabetes, atherogenic dyslipidemia, who have elevated triglycerides, reduced HDL, and small dense LDL. So where do these remnant particles come from? They come from the breakdown of chylomicrons and VLDL. And what happens with that breakdown is, what happens with the breakdown is that the triglycerides are taken out of these molecules, and so they become smaller in size, and they are able again to infiltrate through the endothelium and start the atherosclerotic process. They also have the ability to modify the nature of LDL, making the particles smaller and denser and more able to penetrate into the endothelium. And we know that these remnant cholesterol has a bigger risk if you take them molecule 1-to-1 versus LDL. They can even have an increased risk of ischemic heart disease compared to the LDL. So they are broken down by lipoprotein lipase, and these remnant particles are small enough to penetrate through the intima, and the flag on their surface is even more sticky than ApoB100. So ApoE has a bigger affinity to infiltrate into the proteoglycans which are found in the vessel wall, and the same process happens again. They are taken by the macrophages, they keep swallowing, engulfing them until they become foam cells, and then they induce another state of inflammation, a necrotic core, and then the plaques keep on growing. When we do the blood test, we see the LDL, the triglycerides, and we also see the HDL, and we know that HDL is protective. But the value of HDL alone is not enough. We can have enough LDL, 55 or more, but it is dysfunctional. And we'll not go through how that happens. It's due to the interplay of many enzymes, cholesterol ester transfer protein, lecithin cholesterol acetyltransferase, but disruptions in HDL function, not in the HDL mass, could be therapeutic targets of the future. So as these oxidized particles tend to accumulate inside the plaque, these plaques tend to grow. And as long as they are growing silently, they're usually no big issue. They will cause chronic stable angina, which has a lower risk than acute coronary syndromes. But then at some phase, they undergo some transformation, moving from being stable into becoming vulnerable plaques, and we will discuss that. And then they rupture and they cause the final event, which is either death or a myocardial infarction or acute coronary syndrome. So, why does that happen? It happens by nature of growth. There is a limit to the expansion of the atheroma. If the LDL remains high, LPA remains high, triglyceride-rich lipoproteins remain high, they keep accumulating inside the atheroma until the atheroma simply grows beyond the capacity of the vessel to expand and then they rupture. But this is facilitated by more than one pathophysiologic event. We'll go through them quickly. So the hallmark of an unstable plaque is that it has a big necrotic core and it has a thin cap and its shoulders are full of inflammatory cells, macrophages and monocytes. So these are the three characteristics of the atheroma that is likely to rupture and cause a myocardial infarction. It has a big necrotic core and it has a thin cap less than 65 microns, and we can see that by optical coherence tomography. And they have high macrophage density, especially at the shoulders of the plaque. So why does the plaque, the fibrous cap, get thin? We've seen that the vascular smooth muscles keep producing collagen, and this collagen entangles and this collagen encapsulates the atheroma. But macrophages can secrete metalloproteinases, which tends to break down collagen as second to the exposure of the oxidized LDL. So the cap, instead of being thick, it tends to thin down. Number two, our body tries to repair by depositing collagen. Again, oxidized LDL transforms the vascular smooth muscle cells and disrupts their function, so they are unable to produce enough of collagen. In addition, there are small blood vessels tend to migrate from the adventitia of the vessels, the vasa vasorum, probably induced by ischemia of the vessel wall. This leaky vasa vasorum, as they grow, there's excess production of vascular endothelial growth factor, and so they are prone to rupture. So imagine there's a tiny micro channel at the outer border of the plaque, and then they rupture. They cause intraplaque hemorrhage, and they've helped to expand further the necrotic core. Some microcalcifications on the surface, the thinned capsule of the plaque also tends to weaken it and facilitates its rupture. So growing lipid necrotic component coupled with a thin fibrous cap, breakdown of the fibrin and the collagen, intraplaque hemorrhage from the vasa vasorum, microcalcification, they tend to destabilize the plaque, and then at one moment could be induced by an elevated blood pressure, by some stress, or because of other reasons. Then the atheroma tends to break, and these inflammatory components are exposed to the circulating blood, and so the body senses danger. It's like a bleeding inside the vessel. So the platelets aggregate, they start forming a blood clot on the mesh of fibrin, and this atheroma, on top of it, the thrombus occludes the vessel completely, and here goes the final event of acute coronary syndrome. So the main points that we discussed is, why do we have lipoproteins? Where do they come from, the exogenous pathway and the endogenous pathway? How are they cleared from the circulation? And we agreed that atherosclerosis is a disorder of lipoprotein with endothelial dysfunction. This is induced mostly by the ApoB lipoproteins, LDL, LPA, VLDL, as well as the ApoE lipoproteins, the remnant particles. We've seen how the plaques keep growing until the necrotic core expands further and their surface weakens until they plaque and rupture and end in acute coronary syndrome. Thank you so much.
Thank you very much, Professor Hussein, for this elegant foundation. You've laid all the necessary tools and the foundation bricks for the clinical aspect that we will build on it. And you've shown us how aggressive should we go in treating LDL since it may exert a negative cardiovascular impact. So that takes us to the next session where we will discuss how low should we go with the LDL. And with that, we are very delighted to have Professor Mark Sabatine with us from all the way from Harvard Medical School. And probably Professor Mark Sabatine is well known to all of you. He's chairman of the infamous TIMI study group in Brigham and Women Hospital. He is a professor of medicine at Harvard Medical School, and he is very much internationally recognized expert in cardiovascular medicine, where he has led and contributed in worldwide large-scale clinical trials. And as of now, he has authored over 200 peer-reviewed publications in the leading medical journals across the globe. He's also a deputy editor in JAMA Cardiology, and we've seen Professor Sabatine in various international professional society guidelines in cardiovascular medicine. So, without any further ado, Professor Sabatine, the floor is yours.
Great. Well, thank you. It's a real privilege to be here. I'm glad you're holding this meeting. I recognize all the challenges that are going on.
You are muted, Prof.
Oh, I shouldn't be muted because people heard me. Can you hear me?
Yes, we can hear you.
Okay, good. Fine. All right. So, good. Thanks for confirming. So, yeah, no, thank you. It's a real pleasure to be here. And I'm glad you're holding this meeting despite all the chaos that's going on in the world. And so my wish is that everyone remains safe. I have to say, I wish that before I gave a talk that Dr. Heshmat would always precede me because your talk was fantastic and really set the stage for what I'm going to then dive into for how low can we go. So let me start sharing my slides here. All right. And okay, hopefully that looks good for folks. And so yeah, I've been asked to talk about how low we should go. And the prior talk really set the stage that we really don't need high levels of LDL cholesterol in the blood. The cells can synthesize really what they need. And so we'll talk about the data supporting how low we can go. And here are my disclosures. So if we think about the targets we've had, they have come largely from looking at the experimental arms in a variety of major landmark lipid-lowering trials. The first trial, of course, in this field was 4S. This looked at patients with coronary disease and elevated LDL cholesterol levels and asked, was it worthwhile to lower them? It's useful to think back to that could even be a reasonable question to ask back then. Here in the control arm, the LDL was 190 milligrams per deciliter. And so should we lower that? Of course we should. And that was lowered to 122 milligrams per deciliter with simvastatin and a large reduction in mortality and coronary events. The next trial that followed was led by Dr. Brunwald, who's my mentor, and Frank Sachs, asking the question, what about individuals with so-called average levels of LDL cholesterol? Maybe average is actually not normal. And so different than, for example, the serum sodium, where in a large population, average is 140 and normal is 140. But here, our LDL cholesterols are really driven by the diet exposure that we have. And the bodies really weren't designed to have that. And so in this trial, they then took people whose LDLs were around 135 milligrams per deciliter, that's not actually very different than the current LDL cholesterol levels, even though this was done 30 years ago, in patients with known coronary disease, and look to see whether lowering it with a statin, in this case pravastatin, would reduce the risk of major adverse cardiovascular events. And indeed it did. And you can see here in the pravastatin arm, the achieved LDL cholesterol was 100 milligrams per deciliter, a little bit less than that. And so based on this trial and others like it, then the new target for secondary prevention for individuals with atherosclerosis was now set at 100 milligrams per deciliter. So then the next trial was Prove It TIMI 22, led by Chris Cannon in our group. And now that we had the advent of high-intensity statins like atorvastatin 80, we then compared high-intensity statin versus a moderate statin. And this was in high-risk patients with a recent ACS. And as folks will recall, the atorvastatin 80 milligram arm had a lower risk of death or major CV events. And I've noted here the achieved level in the two arms. We designed this trial such that the control arm would achieve a level of around 100, which we had shown in CARE to be beneficial. And then the experimental arm then wound up having a level a little bit under 70. And based on this trial, as well as another trial, TNT, then the new target for high-risk patients became 70 milligrams per deciliter. Okay, so now we've maxed out on statins. What else can we do? That brings us to the Improve It trial. So ezetimibe had been developed, which blocks cholesterol uptake in the intestines. It lowers LDL cholesterol by about 24% or so. And so Chris Cannon and Bob Giuliano here at TIMI then led the Improve It trial. Again, a large trial, patients with a stabilized after an acute coronary syndrome, and showed that adding ezetimibe to a statin could further reduce the risk of cardiovascular events. But I'll draw your attention to the achieved LDL in the two arms. We again deliberately designed this trial so that the control arm would have an achieved LDL cholesterol comparable to what was in the experimental arm in Prove It. So right around 70 milligrams per deciliter. And then the experimental arm was lower still, right? We wanted a twofer from this trial. First, to show that adding a non-statin to a statin could reduce the risk of major adverse cardiovascular events. No one had done that before. And then two, to see if there's benefit for driving that LDL cholesterol down even lower. And so here, based on this, it'd be reasonable to now target around 55 milligrams per deciliter. Well, but ezetimibe only reduces LDL cholesterol by a relatively modest amount, and so it'd be nice to test the same hypothesis, but with a more potent drug. And that brings us to the PCSK9 inhibitors. And Fourier was the first of the large cardiovascular outcomes trials with a PCSK9 inhibitor, in this case, evolocumab. And it reduced LDL cholesterol by about 60%. And again, I've highlighted here the achieved LDL cholesterol in the experimental arm was 30 milligrams per deciliter, or about 3/4 of a millimole per liter. You look at the interquartile range, and a quarter of the patients were walking around with LDL cholesterol levels in the teens, or at or below half a millimole per liter. No other trial had achieved levels this low to date. And you can see the clinical benefit with a 20% risk reduction in CV death, MI, or stroke. A year later, similar data came out with alirocumab in Odyssey Outcomes. Again, about a 60% reduction in LDL cholesterol. Again, down to levels, in this case, not quite as low as we achieved here, around 1 millimole per liter, or 40 milligrams per deciliter, and a 15% reduction in MACE. Now, you might be worried about safety of getting LDL cholesterol levels this low, but from Dr. Heshmat's lecture, right, you shouldn't have any concerns because, again, the cells can synthesize their own cholesterol. These LDL particles are really the byproduct of the transport of triglyceride-rich lipoproteins to move triglycerides around as an energy source. And then the resulting, after the triglycerides have been hydrolyzed off, then you're left with just cholesterol-rich particles, which are LDL. And those are sort of the garbage particles, which really just need to be cleared. And so for safety here, there's no difference in any safety outcomes between the PCSK9 inhibitor or placebo arm, either in Fourier or in Odyssey outcomes, except perhaps for an increase in injection site reactions, but a small increase in what one would expect for an injectable drug. Now, this is one of my favorite subgroups here from Fourier, asking the question, how low should we go? When we did this trial, the notion was, based on the guidelines, that if your LDL was under 70 milligrams per deciliter, you didn't need to do anything else. You were at target, and there was no point in lowering LDL cholesterol any further. But we had 2,000 patients who we enrolled in Fourier who came in below 70 milligrams per deciliter. You can see we lowered their LDL cholesterol down to 21 milligrams per deciliter, amazingly low. The question is, does it make a difference? If you're already this low, is there any clinical benefit for lowering any further? And the answer is yes. And these are two forest plots. The upper one is the primary endpoint. The lower one is the key secondary endpoint. The black diamonds are the overall effect we saw in the trial. And the filled green squares show the effect in the subgroup of individuals who came in with an LDL already under 70 milligrams per deciliter. And you can see they benefited just as much, a 30% reduction in CV death, MI, or stroke. This phenomenon is seen not only for PCSK9 inhibitors, it's been seen for every class of LDL cholesterol lowering therapy that's shown benefit. And so if you look in the subgroup from the statin trials, who came in with an LDL that was under 1.8 millimoles per liter. If you look at that subgroup in Improve It, I showed you the Fourier data. It was also in the REVEAL trial of anacetrapib. You can see that in all these groups, the reduction in major vascular events per 1 millimole per liter reduction in LDL cholesterol is that same 20 to 22% risk reduction we've seen classically in all the statin trials for people at much higher LDL cholesterol levels. And most recently, Aaron Bahula in our group presented the data from Vesalius-CV. Here I'm showing the CTTC meta-regression plots. To orient you to these plots here, each statin trial here is a square. Where it sits on the x-axis is what the difference was in the LDL cholesterol between the control arm and the experimental arm. Where that square sits on the y-axis is what the observed risk reduction was in either major coronary events on the left or major vascular events on the right. And it's from this work that we have the notion that on average, for each millimole per liter we reduce LDL cholesterol, we see about a 20 to 22% reduction in vascular events. In Vesalius, we got LDL cholesterol down to about 45 milligrams per deciliter. That fits perfectly on these meta-regression lines. Again, from that, one can infer that there is continued benefit dropping individuals all the way down, even into the 40s. And I'm going to take that concept one step further. These are data from Fourier. The graphs are a little complicated, so let me walk you through them here. The top panel is looking at the achieved LDL cholesterol in Fourier, blue in the placebo arm, the red line is the evolocumab arm. The x-axis is where their starting LDL cholesterol was when they came in the trial. The y-axis is where they wound up. For the placebo arm, if someone came in at 100 milligrams per deciliter, they stayed at 100 milligrams per deciliter. The red line is frame shifted down roughly 60%. What we've tried to indicate with the shading for this, with the red shading, is the proportion of the LDL difference between the two arms that was due to dropping LDL cholesterol below 40 milligrams per deciliter. And so you can see for individuals who came in below 90 milligrams per deciliter, there is progressively more and more of the difference between the two arms is due to dropping LDL well below 40 milligrams per deciliter. So for people who came in at the lowest level, about a third of the difference between the two arms in terms of the LDL cholesterol was from dropping below 40 milligrams per deciliter. And so if you accepted that, yes, we should get people down to at least 70, yes, we should get them down to 55, maybe I'll accept we should get them down to 40. But surely if we get them down to 40 milligrams per deciliter, surely there can't be any benefit to lowering below that. 40 is already a really low number. If that's what you believe, then if we looked at a plot of the hazard ratio for major adverse cardiovascular events per millimole per liter reduction in LDL cholesterol, we should see the clinical benefit of evolocumab getting attenuated. Because as we move to the left, more and more of the difference between the two arms is due to dropping LDL cholesterol below 40. If there's no clinical benefit to dropping below 40, then it's just a wasted effort there. And we should see a relatively modest clinical benefit in those individuals to the far left. But what did we actually observe? We observed this. There's absolutely no attenuation in treatment benefit. If anything, benefit's even slightly greater. So I think these data point to the fact that, in fact, for these high-risk individuals, you can't get levels of this toxin low enough. You want to drive them significantly under 40 milligrams per deciliter. This is the EASY PAVE trial that came out at ACC. This is a trial done in South Korea. One of the rare trials to actually randomize individuals to different targets, not to placebo or drug A versus drug B, but to different targets. And those targets were under 55 versus under 70. The actual LDL spread was actually relatively modest, only about 10 milligrams per deciliter. But you can see that then led to a 33% reduction in major adverse cardiovascular events, more evidence supporting targeting lower levels for individuals. Now, I'll share with you in the remaining minutes some complementary data to think about observational data from Fourier, and Bob Giuliano and our group led these analysis, here using Fourier as a cohort, like a Framingham heart study. Here we looked at the association between achieved LDL cholesterol at 4 weeks, the patient's new baseline in the trial, and the adjusted probability of CV death, MI, or stroke. And you can see a monotonic, nearly linear relationship. The lower the LDL cholesterol, the lower the risk of major adverse cardiovascular events. There is no inflection point, right? You can't get your LDL cholesterol low enough. What about safety, right? This was also looked at. Here we've binned patients, those who achieved LDLs under 20 milligrams per deciliter in purple. At the other end, those who were at or above 100 milligrams per deciliter in red. And across 10 different safety outcomes, absolutely no increase for risk. So if patients are worried, oh, is my LDL cholesterol too low? Tell them they don't need to worry. We replicated these data in the Fourier open label extension, now with a longer follow-up, a median follow-up of 4.8 years. Same pattern, monotonic decrease, no inflection point. Again, safety now over half a decade looks terrific. No increase for any of these outcomes in those with lower LDL cholesterol. And this is a slide now moving to a different concept for primary prevention. This was from an imaging study. This is from Glagoff. This was a trial that did intravascular ultrasound. You put a catheter down the coronary arteries and with ultrasound, characterize the plaque that's there. You do it at time 0, and in this case, 18 months later. And this was a trial that in patients on statin randomized them to evolocumab or placebo and looked at the change in plaque. And evolocumab caused plaque to regress. But I find this graph from the trial one of the most interesting ones, in that here, like the analysis we did in Fourier, looking at the association of on-treatment LDL cholesterol with the change in plaque. And what you can see is that if someone's LDL cholesterol is 70 to 90 milligrams per deciliter, on average, plaque remains about the same. If it's higher than that, plaque is growing. And that's why I think for primary prevention, we want to get our patients below 70 milligrams per deciliter. We don't want them to develop plaque. As a cardiologist, I see patients whose arteries have been bathing in high levels of LDL cholesterol for decades. They have a bunch of plaque. We want to regress that plaque. We want to move them as far to the left as possible. And in terms of more population data, this is, to borrow from Dickens, a tale of two studies. Left is MESA, 6,000 people in the United States. Historically, the LDL cholesterol levels about 120 milligrams per deciliter. On the right, the Chimani Health and Life History Project from the Bolivian Amazon, a pre-industrial lifestyle. Their LDL cholesterol is about 75 milligrams per deciliter. In these populations, they did coronary artery calcium testing, a non-invasive CT scan that looks for calcium there, which is a strong surrogate for atherosclerotic plaque. In MESA, the older the individuals got, the more plaque they had over time. What about in the Chimani, who lifelong had LDL cholesterol levels of about 75 milligrams per deciliter, the level at which I showed you that plaque really shouldn't grow? Nothing in these individuals. So coronary disease is preventable if we keep the LDL cholesterol low from young adulthood on. And Dr. Hashmet sort of stolen my thunder for this. This is a paper from 40 years ago where the authors postulated that a level of LDL cholesterol in the plasma of around 25 milligrams per deciliter would be sufficient to nourish body cells with cholesterol. This is 40 years ago. Who were these crazy people who promoted that? This was Brown and Goldstein. This is from their Nobel Prize lecture. So, in conclusion, right, I think in patients who have atherosclerotic cardiovascular disease, you cannot get your LDL cholesterol low enough for those individuals. Under 40 milligrams per deciliter, under a millimole, is both effective and safe. That's what I target for my patients. In primary prevention, I think the data support keeping LDL under 70 milligrams per deciliter to prevent plaque from forming in the first place. Thank you very much for your attention.
So moving forward, we'll shift gears to a relatively different paradigm, where Professor Ahmed Hassoun will take us into the metabolic syndrome, muscle and lipid nexus. And as we all know that metabolic diseases, they don't come in silos, they usually mesh into each other and present probably all at once. And Professor Ahmed Hassoun is known to many of us. He's a consultant endocrinologist based in the UAE. He's a regional expert in diabetes, endocrine, and metabolic disorders. He is fond of dealing with complex cases in both fields of metabolic disease and endocrinology. He's a researcher where he published a remarkably large number of publications in the international peer-reviewed journals. And he is an academic and a teacher where he has contributed in founding or the foundation of multiple educational forums, regional and national, in the United Arab Emirates. So he's the best person to teach us on the interlink between the MASLD, dyslipidemia, and cardiovascular disease. So, Professor Hassoun, the floor is yours.
Thank you very much, Dr. Al-Amin, and thanks everybody for the nice presentation. As you said, we're going to shift a little bit the gear to different things now, and it's going to be. Let me just try this one if it's working. Not working. Here we go. Is it clear now?
Yes, we can see it.
You can see it, right? Okay, just to maximize it here. Okay, continue to share. All right. So again, the talked earlier is very important, and this is going to also very important, a little bit different, but there's some correlation here. So this is my nice hospital, Faqih University Hospital, that I just moved after 4 years of being in the government with the diabetes center. I would like to say there's nothing to disclose for this presentation. What I'll try to do is giving you some combination of things, since we are talking about metabolic syndrome, and then focus more later on the muscle D, the metabolic associated steatoliver disease, and then some issues about the lipid nexus, in a way, the relation with the muscle D, actually. I said cases, probably one case if we have time, and then leave you with some take-home messages there. So I'm sure that most of you know what is metabolic syndrome. This is a simple definition, a cluster of conditions increasing the risk of heart disease and diabetes. The key components simply is increased blood pressure, high blood sugar, excess body fat, waist circumference, and abnormal cholesterol levels. The prevalence is really high, millions, and we will see other prevalence later on about muscle D, which will be even more impressive. So here is the definition I used. There's probably many definitions, but I think this is the International Diabetes Federation definition, which started even from 2006. And I'm sure most of you are familiar with this. So we have to have central obesity, and defined as waist circumference, as mentioned here, with ethnicity specific, that we'll come to later on to see in the next slide. And you can see again what we're talking about: triglyceride, the lipids here, reduced HDL, raised blood pressure, raised fasting plasma glucose, or even having diabetes. So this is the criteria. So you have this obesity, and then the plus 2 of these listed here, which are 4. So that would be the criteria to define it. And we'll come to that also while talking about muscle D. And this is what I said about the ethnic specific things. According to the IDF, you probably are familiar with this, and you can see that different, especially in, for example, in UAE, we have a lot of people from different ethnicities, especially Asians, and you can see the differences between what we are considering waist circumference criteria here is much lower than probably what we use with the European and the North American. Now, moving now to the main subject of my presentation, in muscle D. And I think just to remind you about probably the previous naming of it. Now, this is the definition: metabolic dysfunction associated steatotic liver disease, and that's what stands for muscle D. I'm going to call it muscle D from now on. And characteristic is very simple: fat accumulation in the liver cells. And the old way, what we talked about, and is still valid, is not caused by alcohol. And the risk factors, as you can see it here, is not surprisingly obesity, dyslipidemia, and the insulin resistance. Now, again, back to the old definition, NAFLD was the old name, non-alcoholic fatty liver disease, which is changed to muscle D for good reason, is one of the most common causes of chronic liver disease in adults. And by definition is the requirement of having evidence of hepatic steatosis, either by imaging or by histology. Most likely we see it by imaging, and as we said, no causes of secondary, including the alcohol in significant amount, and also the other listed here. But now we're going to move to the new things. Before I do that, just to remind you about a little bit of the pathology and the spectrum of this NAFLD or muscle D. Now, normal liver tissue. NAFL is only steatosis, triglyceride levels, fat accumulation in the cells in the liver, and then moving to a worsening situation here, which we call it NASH, and we'll call it now MASH. And you can see here there is, in addition to steatosis, there is ballooning, there is inflammation, and the worst part when it's develop and progress to fibrosis and different level of fibrosis. So this is now what we agreed, and they agreed, actually, the consensus, and many society already agreed on using this, and they make it simple. So starting with the umbrella of steatotic liver disease, SLD, and I highlighted for you on the left side of your screen what we are talking about: the metabolic dysfunction associated cirrhotic liver disease, muscle D, and again, the progressive form, which with steatohepatitis, we call it MASH. And you can see the other part of the cirrhotic liver disease, so they are separated more. For example, alcohol is separately. There is sometimes combination with small alcohol or more alcohol, but that's a combined thing. But we are going to focus on really muscle D. And you can see the other things that probably were before included and now they are not included. For example, if you have a drug-induced monogenic disease, miscellaneous and cryptogenic. Cryptogenic probably was included in the old. So this is really a better naming for this, disease. And this is what we can also here correlate what we said about metabolic syndrome. As you can see on your left side, the adult criteria, in a way more clear here to show what it is. And at least he said in this needed for the diagnosis of muscle D to have, sorry for that, to have, let me just go back here, some interruption from the phone. This criteria listed here, at least one of these criteria. Now talking about muscle D. So we have steatotic liver disease, as we said, found by imaging or by biopsy. And then we check, do we have any cardiometabolic criteria that listed on the left, which you can see is the metabolic syndrome criteria. And if it says yes, okay, then we move to further questioning, are there any causes? So we have something now, steatotic and metabolic with it, but is there any other causes other than what we have the muscle D? So if it is yes, then we are moving away from what we are trying to focus. And if we say no other causes, then that's what we have, the metabolic dysfunction associated liver disease. Just to give you some idea about the importance of this, and you can see the development of progression of the muscle D, starting from a normal healthy liver, can progress with time, isolated steatosis, then the progressive form of MASH. And in the MASH, you can see on the middle of the screen, fibrosis levels, stage 1, stage 2, stage 3, stage 4. Stage 4, which is equivalent to the cirrhosis. The worst part of this is this can progress unless we do something about it. And you can see listed above some of the factors that make it worse. And one thing good here about our female audience here, that female sex and estrogen is protective on the healthy liver, while the other factors you can see, especially with like fructose, saturated trans fats, alcohol, and drugs, are worsening effect on the healthy liver and increase adiposity, insulin resistance type 2 itself. And also, surprisingly, I just also learned that primary hypo can increase, negative impact on the healthy liver, in addition to some well-known genetic, ethnicity group. Sorry for that. And on the left, on your right side, on the right side here, you can see the importance of what we like to do. So with aging, you can take the first one, fibrosis stage F0 or F1. So that's an early stage of fibrosis. It will take a long time, to 30 to 35 years to progress basically to cirrhosis or hepatic decompensation. And if it's F2, it's going to be a shorter period. But more importantly, the more advanced, for example, fibrosis stage 3, it only takes a few years to develop. So the point here is, as long as we can prevent this from progressing, an early diagnosis would be better, and preventing it from prognosis and probably managing it, as we will probably come to it later on. And this is the other important part. This is not a benign disease. Basically, if people did not have type 2 diabetes, they are at high risk to develop type 2 diabetes, as shown here, 2.2-fold. Also, very importantly, like what we talked about, LDL and other, lipids diseases that can cause problems with the heart. This one also have been shown there is increased fatal and non-fatal cardiovascular disease, 1.5-fold, heart failure the same, atrial fibrillation even, and also worsening kidney to stage 3 and above of CKD, and extrahepatic cancer, as we can see in the side of the slide here. There is also colon cancer, for example. Cirrhosis clearly can increase significantly with this. And, hepatocellular carcinoma is the end. But what's more important, as we're already talking about, the importance of lipids and protecting the heart, is that really the main cause of the death in these people is really the majority are dying from the heart disease and the complication. And this is just to show you that there is increasing risk of hepatocellular carcinoma in these people with these factors according to the references mentioned here. So the presence and duration of diabetes, type 2, obesity, or both increases. Older age, concurrent alcohol intake or smoking, individuals with FIB4, that we will come to it later, is a calculation we use. Individual with stiffness of the liver, higher level here, as again, we will probably see it later on in further slides that coming. What's more important also is here, look at this slide. This slide published in 2024 about the prevalence, you can see in different parts of the world. But if you look at our region and the MENA region here and other regions, but I can see here that probably the MENA region is the highest in the prevalence, 36+% of people, in this MENA region are having muscle D in a form or another. And you can see it's also higher in other parts of the world, Latin America, even North America, although this probably North America, as you will see later, probably it's higher than that. And if you look at the other parts, Southeast Asia and Australia also, they have high prevalence. So it's not something that's probably, if we talk about metabolic syndrome, probably this is even more than metabolic syndrome in the prevalence if you look at these numbers here. More importantly, in our patients, treated, we have all our patients, for example, as endocrinologists, are having diabetes. Type 2 are the majority of our patients. And you can see here what we're looking at as in people with type 2 diabetes, according to this, again, statistical global prevalence, it is estimated to be globally 55%. But if you look again in our region, the West Asia here, it's probably the highest, including also European there, which is 68%, in our region, almost 67%. And to a lesser degree, again, in the United States, for example, although I think there is studies showing it's much higher than that number, as you probably will see it later on. So it's really an important thing. But more recently, we said 55.5%. There is a new article, Systemic Review and Meta-Analysis, about the global prevalence of type 2, showing that NAFLD, which is now, we should call it muscle D, is even more than 55 in people with diabetes, 65% are going to that. And NASH, which is MASH, we call it now, also in high prevalence. And then there are even, as you can see lower there, clinically significant fibrosis is 35% from the NAFLD, and from basically advanced even worse is 14.9%. Now, looking at the way how to, look into the prevalence, and as I said earlier, in the US, it is probably, as shown in this very nice publication by our friend Ken Kuzi, it was, I think, done probably in Gainesville, or before he moved, he was in San Antonio, looking at the prevalence, and he did it by checking with the stiffness. He did it through the elastography, that we do also, that we will talk about it later. Doing that in people in the primary care clinic, about 561 patients, in this clinic, primary and endocrine clinic, you can see the prevalence of steatosis was 70%. And as I said earlier, this is probably higher than what was in that slide before. So it's really much higher in people with diabetes, including probably everywhere in the world. And the prevalence of fibrosis is even high, 21% of these people having, the fibrosis. What a good message from this slide I would like to emphasize to our people who are seeing such cases: don't look into the AST and ALT. Look at this, the AST, ALT elevation in these people that were studied, it's only 10% elevated for ALT and 6% for AST. So as you will see later, it's important to know about this, but actually you should not focus that if this is normal, then we are safe. It's not actually, and we will talk about it maybe later on. More importantly, again, focusing on the ALT and AST, these people on the fibrosis stage, you can see they are F2 and above. So they are more for the moderate and pre-cirrhosis and cirrhosis, basically. You can see the level of ALT, the prevalence of high ALT and AST, less than 1/3, clearly. So just a message from this slide is, please do not think that AST/ALT is going to very helpful in directing you to the diagnosis of these diseases. This is a recommendation last year from diabetes group in Diabetes Care published, basically looking at what we should do about this. So this is an algorithm for risk stratification for the prevention of cirrhosis in individuals with muscle D. So what they are talking about here, type 2, prediabetes, obesity, or most likely this metabolic syndrome here can be rule out secondary causes and then go ahead and do the measurement of FIB-4 that I will show you later. There's a cut point they use. If it is yes, means it's high, there's high risk of cirrhosis. And then they advise to have the liver stiffness measurement with the FibroScan. And if it is higher than 8, now even maybe it's probably higher than 7, then if it is yes, then it needs to be referred. Although I might a little bit disagree with that, because we probably are able to manage some cases of this before it's coming to be very severe. But at a multidisciplinary group is very, very nice to work it together. But if it is, less than that, and then you can keep a follow-up on these patients. This is what I said to you. It's available, you can download it. It's fibrosis FIB-4, what we call it. Looking at what they are focusing here, ALT, AST, age, and platelet count. I will, and you can see down that the score, which is negative or rule out, or the rule in is put there, less than 1.3 rule out, more than 2.6 is really rule in. And again, the other equation here is the one which is NFS, which I probably like it more in our patient that you will see later on. And here's the new scoring system, and this is done by certain labs, and we are working into getting this to be done in our lab actually. The ELF score, I'm sure in the US and the Western countries there. I'm not sure, maybe in Dubai Hospital with Al Amin, maybe they have that. It's the ELF scoring, and you can see the scoring low risk and high risk here. This is the FibroScan I told you about. We have one, we do it ourselves in our clinic. Hepatology fight with us. They want to do it themselves. And we said, no, we're going to do it. We will refer you the more, advanced cases. So I think all of us here in the primary care, and endocrinology specifically, Dr. Elamin, we need to take care of it ourselves here. Now, just a few words about the food, the dietary in restriction. Again, losing weight, energy deficit using. Some of the food that are restricted or to be avoided really listed here. The processed, ultra-processed, saturated fat, starch, added sugar, and especially fructose. I always tell my patient, please do not take, fruit juice. They will tell you it's fresh or not fresh. It's high in fructose. So some advices about that is good. And the good thing about our Mediterranean diet, that it's all good for anything, for even the cardiovascular or for other things, is a good thing even to implement in our patients here. I probably will not, I don't know about the time, I'll probably quickly, but saying that, you need to have supportive behavior for them, teach them about how to do, and nutrition, as I mentioned earlier, weight loss, probably 7 to 10% is needed, or even more for steatohepatitis and fibrosis. We'll come to that probably later. Physical activity, as for everybody should do, and the alcohol, should be, reduced significantly, especially if people that fibrosis stage 2 or more, they have probably to completely abstain. And I have just recently a case like that, and he is he's used to drink almost a daily basis from his ethnicity, without telling which ethnicity we're talking about. And then he stopped completely. I just saw him 1 week ago, and he said completely stopped. So it's not addictive anyway, and he did a good job. And the behavioral change about smoking and other things, and reducing anxiety and depression. Now, this slide, just to mention what's recently been approved for the use in people with muscle D if they are advanced, F2, F3, and at risk of MASH. So for diabetes management, the famous drug GLP-1 receptor and dual GIP and GLP and pioglitazone. I just highlighted one of this important one. But again, if you have earlier cases, you can do different. But are the important cases here, F2, F3, and even before cirrhosis, actually, because you have MASH pharmacotherapy approved, which is resmetirom, which is beyond our metabolic things, is more of a liver things, but can be treated for this group. And also GLP-1 receptor agonist, the only one approved so far, to my knowledge, is only semaglutide 2.4, basically the higher level of semaglutide. And this is the slide supported that approval for semaglutide. You can see on your left side of the slide, the screen, you can see that compared with the placebo, significant reduction of the MASH without worsening of liver fibrosis. That was the primary endpoint. Always they have 2 points, also more than one or more than one stage reduction in liver fibrosis without worsening MASH. On the other side, tirzepatide is not yet approved, but there is some studies going on it, so we'll pass on telling you more in the future about it. But as I said earlier, the two classes or two drugs that are approved by FDA, and they are recently, one in 24, which is resveratrol, and the new one in August 2025, this is the 2.4. We're not deep, unfortunately, because of time. By definition, it's like a lot about the lipids and about LDL importance, and these are listed here. And the connection between muscle D and lipid is in both. We are talking about fat accumulation. There is also insulin resistance, and there is inflammatory process. This is just a pathogenetic slide showing what's happening in muscle D. Again, looking about the lipids and white adipose tissue, lipolysis. Sorry?
2 minutes, please.
2 minutes. No, okay, no problem. We'll run quickly on that. And that will lead to free fatty acid again and triglyceride accumulation in the liver, causing, with advances of this, to effect on the mitochondria and leading to, the inflammatory process and hepatic fibrosis. Now, I think I have a case maybe just quickly, and then we'll end with that basically. Quickly, this is an Indian gentleman who came to see me for diabetes with obesity. You can see his weight here. It's a BMI 39. Here's the lipids. Not much significant except the LDL, which I think after what we heard is very important. We took care of that, but I'm not focusing about it today. And because of this liver enzyme were elevated, we did the ultrasound of the abdomen, and the ultrasound showed fatty liver. But my message here, if I use FIB4 in this patient, that is his FIB4, and it is low and it cannot help us really to tell that this guy is having, an important thing. Why I'm saying that? Because we went ahead and did for him the fibroscan, and you can see the fibroscan showing very high fibrosis level, and this is translated into early F4, which is early cirrhosis level. And you can see it is in the high risk criteria. FIB4 did not work, but I put NFS, the other one. At least it was indeterminate, so at least you can move ahead and do some other step. And you can see that what's happened. To make it short, he was on treatment for diabetes, and at the same time, he was on semaglutide. Started a long time ago. By the way, he's still on, following with us. And after losing about 10% of his weight, he asked to repeat it, and it was significantly reduced to 9.1 with the help of semaglutide in reducing the weight. And you can see everything improved, including the sugar control here. So my take-home messages is there is an interconnected nature of metabolic syndrome, muscle D, and lipid metabolism. Early detection of the metabolic syndrome and the highly prevalent muscle D is important. The cornerstone of prevention and management for muscle D lies in the lifestyle changes, such as diet and physical and weight management, and pharmacological intervention if necessary. And the last point is elevating awareness about muscle D is urgent. And I've been doing this probably since 2014 about this fatty liver, we call it before. In healthcare, especially given the rising rates of obesity and diabetes, which are expected actually to increase and strain our healthcare resources. And that due to the muscle D MASH advance, hepatocellular carcinoma, cardiovascular complication, hopefully not, but this is probably expected to be in the forthcoming years. And with that, I would like to stop here and thank you very much for listening.
Thank you very much, Professor Hassoun, for this elegant talk. And you just concurred it that the liver is part now of the CKLM, the cardio, kidney, liver metabolic syndrome. So thank you very much for your talk. And without any further ado, because we are a bit beyond the schedule, our last but not least speaker, the cream of the group, is now Dr. Raya Al-Mazrou'i. He is a consultant and chief of endocrinology service in Tawam Hospital in Al Ain. in the United Arab Emirates. She's Associate Professor of Medicine in the UAE University. She has completed her training between the UAE and the United Kingdom. She's specialized in diabetes, adrenal disorders, and pituitary disorders. She has co-authored several internationally peer-reviewed publications, and she's one of the pillars of the Emirates Diabetes and Endocrine Society. Those are the team who makes this success happening. So Dr. Alaya will pile everything up in a case-based presentation, and she will take us through challenging scenarios and personalization in treatment of dyslipidemia. Dr. Alaya, the floor is yours.
Thank you so much. Good evening, everyone. Thank you so much, Dr. Amin, for this kind introduction. And thanks for all colleagues for a wonderful, elegant presentation. So if you allow me, I will share my presentation, and please confirm for me if you can view it. So you can see the slides, I think.
Yes, we can.
Okay, excellent. So hopefully in the coming 20 minutes, we will go through some scenarios and cases. I will start with one case and go through the presentation. And thankfully, I managed to add 2 cases at the end of the day today, where we will apply whatever we will learn through the presentation. So the main idea of this talk today is just to focus on a group of patients where you really struggle with them because the risk estimation engines do not really tell you the story. And this basically are the young patients who do not have the classic comorbidities. So through this coming 20 minutes, we will go through these risk estimation engines, and will focus on the engines that are provided by the recent guidelines, including the ACC 2026 as well as the ESC score engine. And then we will apply the new model addressed by the ACC guidelines, and then we'll go through hopefully the cases and will reflect this on our Gulf and Middle East area. So to start with, this is a 39-year-old male patient, asymptomatic, came to your clinic, routine blood test showed LDL 4.5 and an HDL of 5.8. He has no other comorbidities, no diabetes, no hypertension, no known cardiovascular disease, no smoking, and no genetic disorder. Basically, he is not taking any medication. So if you plot this case in order to calculate the risk score, most likely the risk calculator will give you a low calculated short-term risk. But does this mean it truly means a low to cardiovascular risk in this patient? This already have been elegantly highlighted by the previous presenter. In short, the cardiovascular risk depends on both the magnitude and the duration of the LDL exposure. And this have been already, I would say, by surrogate marker or by the looking for the evidence of subclinical atherosclerosis through imaging, have been shown in a previous study as well as a more recent study. I'm just showing one of these studies almost a decade ago, where they have took patients who are young, between 40 and 54. And these patients are basically cardiovascular risk factor free. So these patients do not have the classic cardiovascular risk factor. And they look through imaging in different parts of the body for any evidence of subclinical atherosclerosis. And surprisingly, almost 50% of these patients have evidence of subclinical atherosclerosis. When they took the subgroup of patients who have strictly controlled risk factor, like for example, blood pressure below 120/80, total cholesterol below 200, hemoglobin A1c below 5.7%, almost a third of these patients have evidence of subclinical atherosclerosis. Not only that, but the prevalence of the subclinical atherosclerosis, as well as the number of sites with evidence of this atherosclerosis, was correlating well with the magnitude of the LDL elevation. So why this matters now? Why this issue is addressed by the guideline? The problem is this is a common problem. All of you are seeing patients coming to the clinic who have isolated elevated LDL. I would say isolated just to make it very easy for you, but it is a common underappreciated scenario. And most of these people are young age. And the young age will powerfully lowers the 10-year risk, absolute risk of risk estimation calculator, even if they have elevated LDL. The absence of the diabetes, hypertension, atherosclerosis disease, atherosclerotic disease make the patient appear in front of you low risk, and also the patient may think themselves they are low risk. But we already know that atherosclerosis is driven by the cumulative exposure over decades. And therefore, the risk engine that you use to estimate the risk of your patient may not be wrong, but basically it is not answering the right question. So in order to address this issue with the patient, you need to go through a journey. And this journey has steps. The first step is individualized discussion about the benefit and the risk, then calculate the risk, then personalize it, then if needed, reclassify it, and then decide the treatment. Through this journey, you will use tool. One of these tools is the calculator, cardiovascular calculator. One of them is the PREVENT that I will address, as well as the SCORE 2 that has been suggested by the European Society of Cardiology as the new upgraded score. You will use the 30-year estimate that is proposed by the PREVENT equation, other risk enhancers that we are going to address. So the first step is individualized discussion. And when we individualize the discussion, it means that you have to explain to the patient what you are talking about when you talk about the cardiovascular risk. What have been mentioned by the previous presenter about the plaque formation, the importance of early and lower LDL needs to be translated in a very easy way for the patient to understand that. At the same time, the patient needs to understand that when we try to help them to individualize their risk, we are emphasizing lifestyle, and we also are trying to balance the clinical benefit of lipid-lowering therapy. This all comes with a cost and with a shared decision. When you talk with the patient and show them the evidence and help with them to make a decision about what to do next, this may not happen in the first or second visit. It may take to you up to 3-4 visits till you and the patient reach a decision. So the ACC 2026 suggests this CPR framework, and the CPR framework starts with the calculation of the risk, then personalization, then reclassification, and then decide regarding the treatment. So we'll start first with the calculation of the risk. And the newly appointed or newly presented equation is the PREVENT equation. And the PREVENT equation basically is different from the previous pooled cohort equation, and that it has been derived from a very large cohort, more than 3 million, compared to 250,000 participants in the previous one. The age range has changed. It is now 10 years earlier, so capture younger patient by 10 years. It removed the ethnicity, however, it captured the social deprivation through the zip code, as this only reflected in US population. It is better calibrated, and therefore, because of its calibration, the risk estimate risk threshold have been lowered because the previous one was leading to overestimation. It has an optional input on it there where you can add other risk factors, including hemoglobin A1C, urine albumin creatinine ratio. The outcome from this score is not just the heart cardiovascular risk, but also heart failure and total cardiovascular disease. And you cannot just only estimate the 10-year risk, but also the 30-year risk estimate, which is very important for young patient. And therefore, as I mentioned, the lipid lower therapy threshold has been downgraded to 3. This is, again, it is equivalent to the previous clinical threshold, but because the previous tool or the previous equation or engine was overestimating the risk, and this one has been already corrected. Now, an important element that I thought it's very important to address here, some people will say why it is a 3%, and this is based on benefit net analysis. And what does it mean? That they calculate what is the number needed to treat, how many patients do I need to treat in order to prevent one cardiovascular event, and at the same time, how many patients do I need to treat in order to get one new diabetes case. The first one, we know that the number needed to treat will go down as the risk is higher. So the higher the risk of cardiovascular disease, you would require less number of patients to treat in order to get benefit. However, the number of case number needed to treat in order to get one diabetes case from statin, this is constant, and therefore they found, or they get the number 3% because it is the crossing line where the benefit equals the harm. But again, this will happen at 3% with moderate statin and around 7% with high intensity statin. However, how to translate this to your patient? Most of the new onset diabetes is basically patients who are at higher risk of diabetes. Most of them are pre-diabetes. Second, most of the rise in hemoglobin A1C will be clinically maybe insignificant, around 0.06 to 0.08%. The cardiovascular benefit outweigh the diabetes risk. And then you need to understand that those patients who are confirmed or predisposed to develop diabetes with the statin are those who have risk factors to that, like BMI above 30, elevated fasting blood sugar, and hemoglobin A1C above 6 in the pre-diabetes range. Another thing to highlight is that the European Society of Cardiology already launched 2025 the new score calculator, which also rather than only predicting the fatal outcome, it predicts the non-fatal cardiovascular risk, and this is in the European region. However, one of the beauty of this calculator is that it has regional calibration, and this regional calibration based on the cardiovascular mortality rate in that region. So, for example, those in the red color have the highest very high risk, where the cardiovascular mortality in this region are above 300 deaths per 100,000 per year. So this is very important point that differs from the prevent equation. It has two parts of it: score 2, where it is applied between 40 and 69, and from 70 to 89 it is a score OP. Now, it used the non-HDL cholesterol as well, and as I said, it has both fatal and non-fatal events. The risk threshold here is slightly different. It starts from 2 to 20%. Now, after using the risk calculator, you will move to the next step. And the next step will enhance the risk stratification for those who are young. The 10-year risk alone is poorly aligned with the long latency between the risk factor exposure, atherosclerosis development, and the cardiovascular event. And therefore, the 30-year risk estimate may be very beneficial in patients where, when you calculate the 10-year risk, it is low, but their LDL is quite high, but not to the range that is suggestive of FH. For example, LDL between 160 and 190. And in this case, it may help you figure out or speculate the long-term risk from continuous exposure to high burden of LDL. The second trigger that also stimulates the estimation of the 30-year risk is when the patient, by the 10-year risk, is low and they don't have the LDL elevation, but still they have other risk factors that you suspect they may have a 30-year risk higher than that. Also, they suggest that it can be used in patients who have diabetes, but they are less than 40 years of age. And in this case, you may use it also to, along with the risk factors, to estimate or to decide whether to start lipid-lowering therapy earlier. So this is just to give you the difference between the 10-year risk and the 30-year. So the 10-year risk, most likely, if you calculate it in a young patient, it will give you the output as low or borderline risk and will emphasize only on lifestyle changes. As we said before, the young age powerfully suppress the score. And you don't put in the score other risk enhancer that we will discuss, which are important for you to take the decision along with the patient whether to start the lipid lower therapy. For the 30-year, this is life course lens, and this is a meaningful because it respect the cumulative LDL burden and exposure, and emphasize the point that already have been highlighted, the earlier intervention. So it captured what we call the longitudinal exposure to LDL over the years. So the two things are basically answering two different things, and they are supportive to each other in the previously mentioned scenario. So with all these calculators, they have improved a lot. They become more standardized, more reproducible risk estimate. You can convey the absolute risk to the patient much easier, provide the 30-year framing, score, provide the regional calibration. Both of them are better than the previous one. What they cannot tell is the cumulative LDL exposure, and they cannot still incorporate other risk factor into the calculator directly. And still there is an age group that is not covered by these risk calculators, which are the one below 30 for the prevent and below 40 for the score 2. But it tells us that this engine and this risk estimate are the first step, and it is not the final answer. You will need them to calculate the first 10-year risk, then you will go to the enhancer, to the 30-year risk estimate, and then you will move to the next step, which is personalization. And in personalization, basically, you are looking for risk enhancer that can support the decision, but they are not yet incorporated into the calculator. And they could include genetic and family history of premature cardiovascular disease, high risk ancestry like South Asian and Filipino, and in some parts of the world they will use high polygenic risk score as well when it is available. Inflammatory disease, chronic like lupus erythematosus, rheumatoid arthritis, inflammatory bowel disease, HIV. Also, they are adding risk to the long term and therefore considered as risk enhancer. Metabolic and CKM syndrome, as well as a higher LDL level below the 190, the usual cutoff for FH, as well as elevated non-HDL. Elevated certain biomarker like lipoprotein little a, or a persistent elevation of high sensitivity CRP, or apolipoprotein B, or persistent elevation of triglyceride. The reproductive history as well is important, as early menopause is a risk factor, as well as other gestational related history. So, however, again, the absence of these risk enhancers are helping you to decide and to personalize the risk. It doesn't mean that if they are absent, the risk is low and you ignore a patient with a quite high LDL for a long time. Again, just overview, lipoprotein little a needs to be checked at least once. This is now highlighted by all the guidelines. If it is positive or elevated, you need to check the family history because it is mainly determined genetically. You don't need to repeat it except when you think that there are other causes that leads to secondary elevation, like liver disease or kidney disease, or a lack of estrogen like menopausal state. And they are the level that is convey a greater risk and is highlighted or acceptable or recommended by the guidelines is the 125 nanomole. However, you could see that the risk already started to rise above 75. However, this is the high threshold that is of significance. We will not go deep in this because it deserves a lecture by itself. Apolipoprotein apply, as mentioned before, directly counts for the atherogenic particles that include all LDL, VLD, and lipoprotein little a, and it is unlike the LDL, which measure only the cholesterol mass. In patients who have CKM or metabolic syndrome, diabetes, insulin resistance, hypertriglyceridemia, the LDL may appear at goal while ApoB remain elevated, masking the residual risk. Therefore, in patients who are already on lipid lower therapy, you may consider checking ApoB if there is both LDL and non-HDL appear achieved and goal, but still you are worried about residual risk, especially those patients with CKM type 2 elevated triglyceride. For patients who are not yet on lipid-lowering therapy, you may check ApoB in case you want to do enhancement of the risk assessment in order to take the decision whether to start a treatment or not. So after moving from personalization, so calculation, already we have the calculators now, we have the personalization where we look for the enhancer, then we may need in selected cases the recalcification. If we didn't take the decision in the second step, at the personalization step, we go to recalcification. And recalcification should be mainly used in those with intermediate or borderline risk, where the decision of lipid-lowering therapy still is uncertain. Then when do calcium scoring, and the calcium scoring is low, 0, mu, and the patient have no other risk factor, like for example, no family history of early onset cardiovascular disease, patient is not having diabetes and not above age 40, no smoking, no FH, then you may defer the treatment and reassess in 3 to 7 years. However, if the patient have any of these factors, actually this may support the starting treatment even if the calcium score is 0. If the calcium score, of course, is high, you will start the treatment. So number one use of it is an intermediate and select borderline in order to decide regarding lipid lower therapy decision, starting treatment if the decision is uncertain. And the second time or the second scenario where you will use it is when the patient is intermediate or high risk and you want to intensify therapy. However, the most important caveat for this is that, remember, there are many patients who will have non-calcified plaque, and these are patients especially with the inflammatory disorder, and therefore you should not use the calcium scoring to differ or withhold the treatment in high-risk individual, like patient with the FH or LDL above 190, or in patient who already has been on lipid-lowering therapy long time because it already increased the calcium score, and you should not use it routinely in low-risk screening individual. This show you how to use the calcium score interpretation, where the score colored here and what is the equivalent risk and what is the recommended plan and LDL target. So for example, without going into details, if you go for a patient who have a score from 1 to 99, then have a risk that is elevated but modest, you could start moderate intensity statin, aiming for LDL reduction from 30 to 50%, aiming for LDL goal less than 100 milligram. And when you go to the categorization now, after you finish all this personalization, recalcification, based on the risk category, you will decide the treatment. I will put it for you here in this table format because it is very easy to understand, where the risk tier is here, the 10-year prevent score is here, the statin intensity is here, what is the percentage of LDL reduction that is recommended, what is the LDL goal, and what is the non-HDL goal. You can refer to this back again and again when you want to take the decision with your patient. So putting all these steps together, the most important thing when you start the discussion with the patient is to inform them about these steps, that lifestyle counseling will remain a cornerstone. You will calculate with them the risk through the calculator. you will end up having a risk category. Then based on the risk category, you will personalize with risk enhancement. And then if needed in selected cases, you will reclassify using the calcium score. And then you will treat based on the score. You will set the goal and will escalate therapy based on the goal. And this is the most important thing. Escalation of therapy to reach the goal is not just a goal in secondary prevention, but it is now even a goal for the primary prevention. This already also has been addressed elegantly in the European Society of Cardiology guidelines, and I just want to show you this flow chart, which I found it is very, very helpful, where you can see what is the risk of your patient, what is the LDL goal, and for example, let's say if your patient LDL goal is 2.6, less than 2.6, they elegantly tell you what to do. If the LDL at the time of starting the treatment at the initiation was less than 5.2, you start high-intensity statin. If it is more than 5.2, you start combination, and so on. So this can help you to decide what to start from the beginning. So back to the patient that I present initially. The patient have only LDL elevation of 4.5. The most important thing you have to do first is to confirm the reading. Go back into the chart. See, is there any elevation on the LDL in the past? If not, confirm this elevation. Look for secondary causes. Apply risk score calculator. Apply the 30-year risk estimate. Take detailed history about the family. Do then risk enhancement. For example, lipoprotein little a, which is now mandatory or recommended to be done for every patient. Look for other risk enhancer and then reclassify and treat. This patient that we presented initially already low risk at the 10-year risk. But if you calculate the 30-year risk by prevent, it is high because the LDL is already above 160. So the recommendation is to start a treatment initially with the moderate intensity statin, and after 4 to 12 weeks, you need to repeat the lipid profile and intensify therapy till you reach the target. Now I will move you to these two cases that I just added them after 5 p.m. today, and I saw one of them today.
4 minutes to go, please.
Okay, I will go through them very quickly. So the first case is a 39-year-old lady, BMI of 34, no history of cardiovascular disease or other comorbidities. Her lipid profile LDL is 3.7. She had persistent hyperlipidemia since 2012, ranging from 3 to 4.4. And today she had a result with lipoprotein little a that is elevated 180 nanomole. The other patient is young lady, 18-year-old, female, BMI also 27, negative history. Lipid profile showed LDL of 4.75, repeated one 5.3, no secondary causes, and she was started somewhere else on combination therapy, statin and ezetimibe, and there is no change in her LDL. We did for her lipoprotein little a, which came back elevated. So if you go step by step through all of them, for the first case, you can see that you cannot apply score because it starts from age 40. If you apply prevent, it will show short-term risk low. However, if you do 30-year risk estimate, it will be elevated. If you personalize with enhancer, she already have lipoprotein little a elevated. She had already high BMI, high triglyceride. ApoB is suggested to be done. We have just sent it today. We didn't do further testing with high sensitivity C-reactive protein, and no need to do calcium score in this patient because already you need to start in this patient on moderate statin. So we had the discussion today. This patient, I saw her several times. Just today she agreed to start the treatment. So it is not necessarily that your patient will start the treatment from the beginning. You need to negotiate with them at each visit and reassess. The second case, already she is a young with elevated LDL, so you need to think of FH. We did FH panel screen, which came back negative, but even if it is negative, does not rule out FH. However, she has very high lipoprotein little a, she have already by this time cumulative LDL exposure. So in this, you can see that despite no classic risk factor, the biology is screaming atherosclerosis need to be addressed from now. And therefore, we start here as well on treatment and as I said before, when she started in combination, the LDL did not improve. So in this patient, we already started here in PCSK9 inhibitor, and we were able to achieve at least 57% reduction in LDL. To put this is one slide. All these engine calculators are not validated in the Gulf region, but we know that our patients have the risk for cardiovascular events at least 10 years earlier than the others. If you apply score 2, mostly it is the high risk region. Prevent, what I like about it is that it uses the clinical framework that we can use it and apply it to our patient who have most of these risk enhancer. So use these engines wisely and try to use the risk enhancer till we figure out and end up using our own calculator. There have been one study that tried to published about Abu Dhabi risk study equation. It is still not validated, but hopefully one day we will have our own. So the common mistake is that when you treat the risk engine as verdict, when you reassure yourself because the patient is young or does not have any other risk factor or they are asymptomatic, when you forget to measure lipoprotein little a, or when you are reassured by the calcium score of 0, and when you don't take deep family history. So to take the take-home message here, atherosclerosis is a life course disease. Low 10-year risk in young people doesn't mean low true risk. Apply the CPR framework, which is very helpful in our population. Risk enhancer, change the conversation. Thank you so much for your listening.
Thank you very much, Dr. Raya. This is an amazing journey through various clinical applied cases, and you've piled all what have been mentioned earlier, and you spiced it up with the international recommendation. Thank you very much. So we are way beyond the schedule, but we have enjoyed all the talks. So we'll try to, may I ask all the speakers to join us, please? And we'll have quick questions and quick answers, please. And may I start with Professor Sabatine? A question. Now, the ApoB is solidly seated in the international guidelines. What about the other APOs, ApoE, ApoA? Are they clinically available to be prescribed or requested? And on top of that, what's the role of family medicine physician or primary care physician in requesting those the ApoB and lipoprotein little a at the primary care settings?
Yeah, no, it's great. Thanks for beginning with me. I have other work to do in the hospital, so unfortunately I can't stay beyond this question. It's a great question, though. I would say that ApoB certainly has been shown to be a somewhat better predictor than non-HDL cholesterol, and both of those are a better predictor than LDL cholesterol. And it's just a function of how laboratory testing has been done that we remain focused on LDL cholesterol. I think it's certainly prudent to get an ApoB to make sure that you're not misascribing the risk, that someone has lower cholesterol but a lot of particles and their risk would be higher. So I think that's something prudent to get. The LP little a, as other speakers rightly noted, should be checked at least once. And there's some data there's actually variability for LP little a despite its intense genetic control, but at least once to make sure that someone isn't elevated. What to do for that? Statins don't affect LP little a. PCSK9 inhibitors reduce it by about 25%. And we and others are doing large trials studying LP little a inhibitors, dedicated inhibitors. And I think the last point about family medicine, I think as many other people touched upon, that LDL cholesterol is unfortunately a lifelong risk factor. And the guidelines are currently sort of inverted, that we focus on people intensely after they've had a heart attack or a stroke. we really should be focusing much earlier in terms of prevention. And that's where I think the family practitioners can play a huge role in educating people that they really need to keep their LDL cholesterol down from young adulthood going forward. Lifestyle would be great. For most people, that's not enough. And luckily, we have a lot of medicine options. I'll just say I enjoyed all the talks, really outstanding content that all the speakers provided. Unfortunately, I have to run off to a different part of the hospital now, but thanks so much for having me.
Thank you, Dr. Sabatin. Thank you. Looking forward to have you again. Okay, so we move on. Dr. Hussein, almost all of the speakers have agreed that the LDL should go quite low. So the very low LDL, is it only it comes only with a positive outcome, or it may have an adverse outcomes like dementia, and also you can touch on the dysglycemia with the statin therapy? Short answer, please.
Yeah. So there has been always a concern about cognitive decline with LDL lowering. And two comments on that. Number one, the latest meta-analysis done on thousands and tens of thousands of patients didn't show an increase in the rates of Alzheimer's disease or dementia with the use of statins. But it has been described that there is some transient and reversible memory impairment with statins. And as I said, it's transient and mild memory impairment. And it seems to be peculiar to statins because there is a specific subgroup analysis from the 4-year, it's called Ebbinghaus, where they have done sophisticated neurophysiologic testing, including patients who have reached very low levels of LDL, and they couldn't find any meaningful cognitive decline with PCSK9 inhibitors. So it's not related to lowering the LDL, but it could be related to statins and not to PCSK9 inhibitors. One final comment is that LDL does not cross the blood-brain barrier, and the brain is able to synthesize its own cholesterol.
Excellent. Thank you very much. Dr. Hassoun, we know that, and you have alluded to, that the muscle is a high cardiovascular risk phenotype. Why don't we see the muscle D as part, at least, risk enhancer in the cardiovascular risk stratification engines? It's not a determinant, but not even a risk enhancer. What could be the reason behind that? Dr. Hassoun.
Yes, sorry, it was muted. What I'm trying to say is that, it's something all progressing now in the knowledge about this, but clearly there is increasing, risk of having heart disease. So directly from what we know from the studies about that, it should be considered. And now, as you know, Dr. Al-Amin, as you said, cardiometabolic, having the dyslipidemia, most of them, and they have to be treated accordingly. But to put as an enhancer, it should be, but I don't think there is any yet agreement on putting it this way. But it's very important to treat it as really a cardiovascular risk, as we saw even before having cardiovascular. And actually, it's probably recommended to do, if somebody have only muscle D, to go ahead and check for hours. But that's not all approved. But I think thinking about it, it should be probably considered if somebody having this, as we talk about other things, then maybe need to look into the cardiovascular situation, whether it is there's some silent disease, especially in people with our patients like diabetes.
I agree. Thank you very much, Dr. Hassoun. Dr. Nada, there is a question on the lipid-lowering agents in the females at childbearing age. Are they safe? Would you prescribe it safely and abundantly, or you have to have some precautions? Dr. Nada?
Yeah. Thank you very much for these questions. Yes, actually, this is important questions because currently, as we know, that the black box label has been removed from even during pregnancy. So as we knowing this, more data toward safer statin therapy and those age group. Statin are, before we know it's contraindication during pregnancy, but nowadays by removing this, so it's more safer. But about child aging group of people, usually I advise the people soon as they know they get pregnant, maybe they need to seek their expert about getting their opinion. And at that time, we are risk stratify those patients if they are really high risk or moderate or low risk. Based on this, maybe we need to put our recommendation, so it will not be generalized. It will be again, it's case to case difference. It's individualized case, who you want to continue their statins during pregnancy, who you will hold it, you will think about alternative methods.
Okay. Thank you very much. Dr. Raya, you've walked us through the various cardiovascular risk engines. The question is, what's the most suitable CVD risk engine calculator in our region?
So, as I have mentioned last time, last slide, none of these have been validated in our population, but our population is high risk. So, if I think to use these engines, I will use the score 2 high risk region for the 10-year risk, or I would use the prevent and the frame score to personalize. And I think using the the framework of the CP classification is the most applicable to our region, in my opinion.
CPR.
CPR, sorry. Calculate and then personalize and then reclassify, classify.
Yeah. I agree. Okay, thank you very much, Dr. Hussein. In practical terms, what triggers initiation of the dual combination or triple combination, or moving to the advanced medications, anti-dyslipidemic medications from the start? So can we start, for example, the newer agents from day one of diagnosis of dyslipidemia?
Yeah, like we do in hypertension, we have the rule of 10 for systolic blood pressure. So every medication is able to reduce the systolic blood pressure by 10. So it's kind of predictable. The same applies to LDL and different agents. So we know that high intensity statins would give us like 40 to 50%, and then PCSK9 inhibitors 50 to 60, ezetimibe 25%, bempedoic acid somewhere like 30%. So we know the magnitude of each medication. And we know two other numbers: the risk of the patient, which dictates what's the target LDL, and the baseline LDL of the patient. So we start, for instance, with an LDL of 200, and the patient is high risk, and we know that we need to go below 55, for instance, a myocardial infarction or a recurrent event. So we know beforehand that a high intensity statin alone, at best, will bring the 200 to close to 100, but we still need another 45 milligrams of reduction. So we would start upfront with a combination of high intensity statin and ezetimibe. If we start even higher, let's say in a heterozygous familial hypercholesterolemia and high cardiovascular risk, let's say we start with 250, then we know that combination of statin and ezetimibe alone will not get us through the target. But in real life, the biggest barrier I see is the access to the medications, either because of lack of funding or because of insurance rejections. So eventually we are forced to go through the funnel of the insurance, where we start by high intensity statin ezetimibe. We wait for 6 weeks. If it doesn't work, we prove it to the insurance, it didn't work, and we start the fight for a PCSK9.
Thank you very much. Dr. Hassoun, quick question, quick answer. What are the barriers of
We have the expert of the lipids with us here, and maybe I ask anyone can answer. The idea is to reduce the LDL to a certain target, as we do. Now, if somebody is having a target, let's say less than 70, and his LDL cholesterol is 110, why we are not considering combination from the beginning into a lower dose statin with ezetimibe, and you will achieve the target. And also, probably is going to be less of side effects, as we talk and all of us agree that 20% of the statin will only increase 7% on the benefit on the reduction. While if you're adding, the ezetimibe, it will add 25% reduction rather than the 7%, and you can achieve the target. So I know we are talking more about advanced cases, but let's talk about the common things that we see in diabetes, for example. They are not very high LDL. So why not we thinking about that? I personally, and many colleagues of my cardiologists even, they are doing the same. They're starting from a combination from the beginning, even that probably they need to increase the statin, but they're not doing that. They, adding the ezetimibe. So to make it short, I need your answer, please.
Yes, I just didn't have time to go through the entire spectrum. I've discussed the extreme cases where you need to hit strong and from the beginning. But as you eloquently mentioned, if you have a patient, let's say who's a moderate risk, the 10-year risk is like 7.5%. And we start by an LDL, let's say, of 120, and I need to bring that down to 70. Then I would start with a moderate intensity statin. And I see him in 6 weeks. If it works and that's expected, then I'm very happy with that. So it all boils down to where you're starting and where are you heading and the strength of each tool that you have.
Thank you. Thank you.
Thank you very much. We have still lots of questions piling up, but we are way beyond the schedule and we've kept you until very late hours of this night. It was enjoyable. It was an enjoyable educational session. Thank you very much for all the speakers who have spent their time preparing those talks. And we will be seeing you more in the future waves, inshallah. Thank you for the colleagues who stayed also during their leisure time until late hours from within UAE and even from the region. And I'd like to thank the organizers and the Emirates Diabetes and Endocrine Society and MCI for arranging this activity. And we would like also to thank Amgen for supporting this wave of dyslipidemia masterclass, and looking forward to have the next wave very soon, inshallah. Thank you all and have a lovely evening.
Thank you.
Assalamu alaikum.
Assalamu alaikum.
Thank you so much. Shukran.